Hello to everybody. I'm Dr. Fouladvand, the moderator, and near me is Dr. Takagi, who is the second moderator, and we are glad to be here in this session to hear the young people, what they did in their work. Dr. Takagi, I give you the word now.
And we have 7 presenters here, and we also have 3 special panelists, Dr. Rin, Dr. Modi, and Dr. Singh. So, shall we start? Okay, the first presenter is Dr. Yan, and his lecture is a non-randomized clinical registry of the DynamX Novolimus Eluting Coronary Bioadaptor system in the treatment of patients with de novo native coronary artery lesion DynamX Hong Kong registry. Dr. Yan, please start your lecture.
Thank you. Okay, thank you for the opportunity to share some of our early experience with the DynamX Bioadaptor from our Hong Kong registry. Here's my disclosure. So the best-in-class DES do well in the first year, but event rates increase after the first year at a rate of about 2 to 3% per year. And studies have shown that the MACE rates of about 21% at about 5 years from the Resolute All-Comers trial and up to 46% at 10 years at the ISO Test 4 study. The DynamX Bioadaptor is a novel coronary device with a novel uncaging element in the implant design with bioresorbable polymer, which is resorbed over 6 months, releasing the uncaging elements and allowing implant to move with the vessel wall, adapting to the vessel physiology. The Q performance of the DynamX Bioadaptor is everything you would expect from a best-in-class DES. There's no change in implantation technique with excellent deliverability. The drug Novolimus is eluted over 3 months, and the thin PLGA bioresorbable polymer coating is resolved over 6 months, allowing uncaging of the elements you see in circle. The Bioadaptor has a thin cobalt chromium strut design with 71 micron, with a radial strength similar to best-in-class DES, and has demonstrated excellent neo-intimal coverage from studies up to 99% in about 12 months. So allow me to explain a little bit more about the design of the Bioadaptor in more detail. So there are 3 uncaging elements per ring in a circumferential pattern, in helical pattern, which are held intact during implantation. And the bioresorbable polymer coating that provides support needed during the implantation and the healing phase. And over the next 6 months, this polymer coating is resolved, allowing the uncaging elements to disengage and safely to allow positive adaptive remodeling and restoration of the vessel function, such as conformability, pulsatility, and dilatation. And also allows the vessel to return more towards its baseline angulation with less vessel straightening that you would see from a drug from a stent. So positive adaptive remodeling occurs when the coronary artery can remodel or expand in response to atherosclerosis or disease progression, and this preserves the lumen area and blood flow over time. A vessel treated with the SAVC and the top images that the vessel is caged and the stent cannot grow with the vessel. And the vessel will mostly undergo negative remodeling or decrease in lumen area due to restorative tissue growth. With the DynamX Bioadaptor, it is designed to release the uncaging elements after 6 months, and the vessel segments allowed to become unconstrained. You can see in the low row of images. This allows the vessel and the device to grow in diameter with the vessel to maintain lumen area. So the vessel compliance, I think, is an important factor to maintain healthy coronary vessel function. And the vessel can respond to the normal stress and strain of cyclical pulsatility that you would normally see, and motion, which may impact on disease progression. So this is a stationary OCT with no pullback from the DynamX mechanistic clinical study, which was published by Professor Farhat in Europe PCL last year, which demonstrated that after uncaging, the DynamX adapter allows for the vessel pulsatility and motion. You can see here, this is and you can see, Okay, you can see that the vessels are allowed to move, and you can see the. Oh, hang on a second. Oh, hang on a second. So when after this Sankey allows for the motion with the vessel, you can see the vessel will able to expand and contract during systole and diastole. There's a still image of that. And in this clinical example, the lumen area shows a 14% change between systole and diastole. And the Bioadaptor also shows about a 9% change between systole and diastole. And this translates to about 30% increase in blood flow between systole and diastole. So the DynamX Hong Kong Registry is a prospective non-randomized multi-center registry aiming to confirm the acute procedural success and the long-term outcome in 50 patients with up to 2 de novo lesions with reference diameter of 2.25 to 3.5 millimeters and length of up to 34 millimeters in length. So the clinical endpoints includes acute procedural success and target vessel failure up to 1 year. So unfortunately, the study commencement and recruitment was delayed due to the COVID restrictions. As a result, the first patient was only enrolled in October last year. So today, I can only share with you 19 patients, which has been enrolled from only one hospital, which is my hospital, but the registry is ongoing. So here are the baseline characteristics of the first 18 patients and 20 lesions. It's very typical patient you will expect with a very high percentage of risk factors, including diabetes, hypertension, hyperlipidemia. About half the patients are stable angina, the other half is ACS. Locations about most of it is in the LAD and LCA, and some in the low circumflex. And these are predominantly simple lesions, type A and type B1 lesions. And the diameter average about 3.28 and the length of about 18.9 millimeters in length. Since the first patients are enrolled in October of last year, we don't have only 30 days outcomes for the first 13 patients. You can see here the performance of DynamX Bioadaptor was probably expected similar to other best-in-class DS with excellent acute success. There was one case of failure to cross by the Bioadaptor due to unexpected calcification proximal to the target lesion. But overall, you can see here excellent safety profile was observed up to 30 days with no major adverse events. So this is really preliminary data, but from what we can conclude is that DynamX Bioadaptor performs acutely similar to best-in-class DES. The implantation technique is the same. Durability, conformability, and radial strength is similar, is maintained while the vessel heals. And the Bioadaptor is showing good acute performance in this fairly real-world sort of patients. And the DynamX Bioadaptor demonstrate excellent safety after 30 days follow-up with no adverse events. And while early in the follow-up phase, the Bioadaptor performance is in line with the excellent result demonstrated in the 50-patient DynamX mechanistic study, which I mentioned was published in Europe PCL last year by Professor Farhat. But there are ongoing registries and also multiple randomized studies to confirm the clinical efficacy and safety of this new Bioadaptor compared to other conventional DES. So discussion, hopefully this may represent the next generation beyond DES and bioresorbable scaffold, which allows the positive remodeling, which we believe is probably an important function, and also able to allow the vessel to return to its baseline ankylation and about to also retain the cyclical pulsatility that you will see in a normal vessel. And so far, the acute performance we have observed is similar to other DES. So thank you for your attention.
Thank you very much, Dr. Yang, for your interesting presentation and this interesting stand. Now, the audience, if someone wants to give some questions, we are ready. And more questions better for the presenter, no? More questions better for the presenter. So please.
Let me ask one question. Why this kind of uncaging system provides positive plate remodeling or pulsative motion?
So, why? Because when it's uncages, so the stents are allowed to expand radially with the vessel as it goes. So that's when, with normal vessel, you would see if you do a static OCT on a vessel, you will see systole and diastole moves. And so we've shown that it allows that. So when you uncage, so the radially there's the delinked. Okay, but longitudinally it's still maintained, but radially they're delinked so that the vessel at any point is allowed to, move with the vessel, when with the pulsatility, and also when it delinked, it actually allows the stent to be more to the vessel to return more to its original, contour or geometry per se. So. Not so far from our study, but the other study have shown in 6 months' time when encage occurs, you see the angulation of the vessel returns more towards its original.
So it may reduce the radial force.
The radial force is maintained up to 6 months because that's before it encages, before it resolves. So it is maintained at that point, and so there's no evidence to show that it actually reduced the radial force. And the study have shown in the BRS era where beyond 6 months, we may not actually need the whole concept of BRS is that long term you don't need the scaffold per se. But here, the scaffold remains, but is allowed to conform. So we don't have any long term data, but at least up to 6 months in the European first in man study have shown there's no real degradation in radial strength.
One question from me. Well, it's very interesting to have a stent that can respect the anatomy and the physiology of the vessel. But by the way, placing a stent like that doesn't need a very good preparation of the lesion, predilatation, something like a bioabsorbable stents to prepare the lesion, not to have after placing of the stent recoil. Do you have some experience about that?
Yes. So I think for the first 6 months, essentially should behave like a normal stent, but because of those encaging elements, that the stent construct may be weaker, as you say, than the normal DS. So yes, by protocol, that we require optimal good pre-treatment, pre-dilatation with at least less than 30% recoil after balloon angioplasty before we implant this. So it's still early experience. So we try to avoid, by protocol, to avoid heavily calcified arteries, and then to make sure that the vessel is dilatable by angioplasty, by balloon, before we implant this stent. So it's still early experience. We're trying to optimize that to, as you said, to prevent.
Last question with a very quick answer. Do you have the intention to use some imaging at your follow-up of your patient, particularly OCT, because as I understand, the movement of the stent is important, the artery movement is important. So do you intend to use some imaging in your follow-up?
Yes, so all our patients had OCT at baseline, at the implantation, and we plan, it's not by protocol, but in our center at least, we're inviting all patients to come back for.
Okay, thank you very much for your fantastic presentation. And I'm giving the word to my co-moderator, Dr. Takagi, to present the next presenter.
Mr. Moderator, can I ask one question, please?
Yeah, you have.
Bryan, interesting concept here. I'm very interested to know about the long-term technical outcomes. How would you treat your patients as far as DAPT is concerned? Do you use 6 months, 1 year, or the data is still evolving?
We use just by standard. We're using like 6 months as per guideline.
Okay, good. Thank you so much.
So let's move on to the next. The next presenter is Dr. Andy from Singapore, and title is the impact of side branch dilatation for the treatment of bifurcation. Please start.
Yeah, okay. Good day, everyone. Yeah, I'm Jaryl. So today I'm going to present an in vitro study on the impact of side branch dilatation for the treatment of bifurcations. So we have no conflicts of interest to disclose. So as we all know, single stenting is obviously the preferred method for provisional stenting in bifurcation lesions. And previously there have been results to show that jailed shreds protruding into the side branch ostium are potential locations for stent thrombosis to develop and occur. And so what this study aims to demonstrate is the potential benefits of opening the side branch to reduce the amount of acute stent thrombogenicity in the bifurcation ostium. So we use this in vitro model with dimensions shown on the right, and we compared 3 techniques using the Zine Sierra DES. So first, without any side branch dilatation. Secondly, with the sequential SB dilatation, and finally with kissing balloon. And for each of the models, we perfuse them with porcine blood for about an hour at 200 ml per minute. Yeah. So I look at the OCT, we see that into the side branch, we see that without any side branch opening, we do see the floating shreds disrupting flow into the side branch, and we do see a significantly less presence of floating shreds for both the SBD as well as the kissing balloon strategies. So how do we analyze our results? So basically our result analysis would be just the bifurcation ostium. So for the shred analysis, what we did was to quantify the amount of floating shreds in each of the frames in the bifurcation ostium from OCT poolback and average it. For thrombus quantification, we use 5 frames within the bifurcation ostium with the largest thrombus area after flow provision, and averaged it as our results for each model. Yeah, in addition to experimental results, we decided to add in some computational fluid dynamic models that were created based on these OCT poolbacks, and simulated them based on the flow conditions similar to the experiment. And what we did was to measure shear rate above physiological levels, specifically 1,000, to see whether the area of high shear rate is correlated with the amount of thrombus formed. So these are examples of the models, one without opening side branch and one kissing balloon. So looking at OCT results, so firstly we do see a pronounced reduction in floating shreds after opening the side branch as expected. And this did translate to a numerically lower thrombus form in both the SBD as well as the kissing balloon inflation models. And looking at our CFD quantification, we do see that, that without opening the side branch, we do see significantly higher area of high shear rate compared to the models with the side branch open. And we believe that this area of high shear rate actually relates with our experimental thrombus formation trend, with KBI consistently being the lowest in terms of thrombogenicity. And for more visual representations, we do see that regions in red will be the regions that have high shear rate, and we see that in without opening the side branch, we see large flow disruptions. However, we do not see as much in both of the techniques. Yeah. So some discussion points we have for this. We noticed that although SB dilatation does reduce the number of floating struts, sequential SB dilatation creates some form of malapposition, sometimes in the main branch opposite of the carina, which might have contributed to a slightly higher acute thrombogenicity compared to kissing balloon. And we do see that KBI doesn't have this issue at all, which in turn showed the lowest amount of thrombus form. And also this bench study is actually in contrary to clinical studies that show no impact of final kissing balloon dilatation in single stenting in bifurcations. However, we have to note that this is just at the core, it's an idealized model for experiments. It might not be physiologically directly representative. Yeah, so in conclusion, we believe that SP intervention strategies have shown to be effective in reducing the number of floating struts and subsequently acute thrombogenicity in the bifurcation ostia. And we believe that in vitro benchtop models are still useful for understanding acute thrombogenicity. Yeah, and as well, however, we believe that further experiments are needed to establish the clinical impact of routine side branch strut dilatation on long-term angiography as well as clinical outcomes. However, we still think that comparing routine SP intervention, our benchtop analysis still supports KBI over sequential SBD if we want to open the side branch in terms of acute thrombogenicity. Yeah, that is all. Thank you.
Thank you for the presentation. Any question or any discussion?
Well, Dr. Nguyen, I have to say that your presentation is really very interesting, and contrary to the consensus document of the Bifurcational Club, and probably it will be very interesting to hear your presentation at the Bifurcation Club, because all the studies and consensus document says that if the side branch has a good flow, the flow is good, don't touch it. But my question is, in your bench model, the diameter of the side branch, how many millimeters was?
I believe it was, we go towards it.
How much?
2.5, 2.75, yeah.
Okay, thank you. Some questions from the audience?
Yeah, actually, very nice presentation.
Yeah.
You're right to finish off by saying that, I mean, the current studies actually don't support side branch pre-dilatation unless there is a compromise in hemodynamic instability or symptoms.
Yeah.
Well, this is a bench test, and if you're going to touch the side branch, and especially if you're going to do kissing balloon, then you definitely, then comes about the question whether you should actually finish off with a pot, because then you alter the geometry of the whole stent. I guess what you can do ultimately is, if you want to know whether you decrease thrombogenicity, is you have to take dedicated bifurcation lesions with a provisional one stent and compare it to short-term versus long-term DAPT duration. But nonetheless, I think always research like this triggers our mind for more questions and more research. Thank you.
Yes, thank you very much for your input.
Well, Dr. Ramesh, I have to say that the dedicated stents for the bifurcation, there remained only one or two, a bio stent and...
No, I didn't refer to dedicated stents. I mean one stent technique for bifurcation lesions. I don't believe in dedicated bifurcation stents.
Like all of us.
Yeah.
Well, I think that we are very good with the time, and I will ask Dr. Takagi to present the third presenters.
The third presenter is Dr. Osheiba from Birmingham, and the title is In Hospital and 12 Months Outcomes of Left Main Percutaneous Coronary Intervention. Dr. Osheiba, please start.
I'm Mohammed Osheiba, Honorary Specialty Registrar in the Interventional Cardiology Department at Queen Elizabeth Hospital, Birmingham. I'm honored today to present our abstract in this great meeting when the culprit is the left main and hospital and 12 months outcomes of left main percutaneous intervention, a single center experience. I have nothing to disclose. Recently, the Excel trials have demonstrated that the PCI and CABG have a similar clinical outcome for left main disease. PCI is now increasingly used in revascularization of patients with left main disease in place of standard treatment of CABG. Left main PCI is one of the most important PCI prognosis and risk adverse outcomes, despite recent advances because of the large area of myocardium at risk that can quickly cause hemodynamic compromise. So the site of our study is our tertiary center, Queen Elizabeth, Birmingham. Our study, we investigated patient characteristics, clinical presentation, procedure details, and key factors for associated with adverse outcome, both in hospital and at 12 months follow-up for left main PCI. We retrospectively evaluate all left main PCI procedure performed at our tertiary center from the 1st of January 2015 till the end of 2019. The procedure data were collected from our PCI database, and 12 months follow-up obtained from routine follow-up visits. Inclusion criteria: all left main PCIs, including patients presenting with cardiogenic shock, and exclusion criteria was only aborted procedure. With among more than 4,600 procedures over the 5 years, we found 250 left main PCI procedure represent 5.3% of all procedure. 2 incomplete procedure were excluded, so we include 248 procedure for 239 patients. The mean age was 72, and the may represent nearly 72% of the whole population. We categorized the procedures into 2 groups. Procedures were done for patients presented with ACS, and it represents nearly 2/3 of all procedures, 67%. Among this group, there was nearly 1/4, 23.5% presented with ischemic, and 13% presented with cardiogenic shock, and 9.6% had out of hospital arrest. And the other group was for procedure for stable ischemic heart disease presentation, nearly 33%. For the clinical characteristics, there were no significant difference between both groups regarding demographic data and the post-medical history. The main risk factors were hypertension and hypercholesterolemia and well-established coronary artery disease. For the procedure details, the only significant difference between both groups was use of intracoronary imaging with higher tendency in the stable presentation to be used, represented by 82% in the whole, 82% for all stable presentation, compared to 66% in the ACS group. Regarding other details, no significant difference. For rotablation, nearly around 15% in both groups. The radial axis was the main axis in both groups, and unprotected left main was treated in 89% of patients in the ACS group, compared to 77% in the stable presentation. Left main treated as a bifurcation in nearly 1/4 of cases in both groups, and multi-vessel intervention was done in nearly 40% in both groups. For the in-hospital outcome, there was a significant difference, definitely in hospital stay, duration of hospital stay between both groups, with a median only 1 day for the stable and stable group, and 3 days with interquartile range from 1 to 7 in the ACS group. Regarding the procedure outcomes, there was definitely a significant difference between 2 groups with higher incidence of complication. In the ACS group, driven predominantly by higher incidence of in-hospital mortality. As you can see here, 25 cases represent 15% of all procedures. If we look in detail in the measure in hospital measured adverse outcome, defined as in-hospital mortality and non-fatal MI stroke, 50 in the ACS group, we can find 15.6% of all procedure in the ACS group had measured adverse outcome, compared to 3.6% in the stable group. So we did a multivariate analysis to predict the in-hospital measured adverse outcome, and we found that the cardiogenic shock was the main predictor, with odds ratio 7.8, followed by not using intracoronary imaging by 3.68, and the femoral axis 3.27. For 12-month follow-up, there wasn't any significant difference between both groups for the major adverse outcome and the need for repeated revascularization and hospital admission due to heart failure. For the survivor analysis, for 1-year survivor analysis, there wasn't any significant difference between both groups, and there was no independent predictor for 12 months mortality were found in the multivariate analysis regarding the measure outcome, 12 months mortality. Conclusion: left main BCI for ACS carries a high risk for adverse in-hospital outcomes, driven predominantly by cardiogenic shock, not using intracoronary imaging, and use of femoral axis. at 12 months follow-up, no significant difference was noted between left main PCI for SS or stable spinal heart disease regarding the measured adverse outcome or need for repeat revascularization or hospitalization for heart failure. Thank you for your attention.
Can I ask the usage of the intra-aortic balloon pumping or intra or something like that?
Yeah. Actually, the data for circulatory support, there is a lot of cases that circulatory support, but the data for circulatory support I couldn't with it. Maybe if extend my my study, I'd find add need for circulatory support.
Just a very short question about the left main stenting in your study. I didn't saw the description about the 1 or 2 stent strategy. Probably, maybe I missed something, but I think that you didn't mention whether the groups is a predictor of some unfavorable result, particularly in the follow-up. Do you have some data about that?
Yeah, I have the data, but it wasn't significant predictor for any bad outcomes, adverse outcomes.
Well, Dr. Osheiba, I have to say that your presentation was really very good for all the group of the interventional cardiologists, because in the acute situations, we have to do angioplasty in the left main, and your result demonstrated that in the stable patients, left main stenting is equal to the have a good result. So thank you very much. Some other questions? Well, if there are not other questions, I will ask Dr. Taji to present the next presenter.
Okay. Next presenter is Dr. Pura from Indonesia, and title is Safety and Efficacy of 2 stent strategy versus 1 stent strategy for bifurcation lesion. Please start.
Good afternoon to all moderator and panelists. This evening, I will present my study about safety and efficacy between 2 stent strategy versus 1 stent strategy for bifurcation lesion meta-analysis with time frame follow-up. I have nothing to disclose, and as we know that bifurcation lesion remains challenging in PCI, and even the last guideline advice that professional strategy is better than 2 stent strategy. However, the event of stent thrombosis and stenosis remain high. And then the several RCT from the Asia, such as decay crash or the definition to trial the last study said that 2 stent strategy is associated with a better outcome. And the previous meta-analysis have been built without regard to the duration of follow-up study. And I think it's like unfair is we compare the study in the 5-year and then study in just follow-up in 6 months. So I try to make this study to assess safety and efficacy between 2 stent strategy between 1 stent strategy based on follow-up time. So I conducted systematic search in PubMed, ScienceDirect, Cochrane, and ResearchGate in October 2020 with inclusion criteria RCT, which comparing 1 stent strategy versus 2 stent strategy, and have completed follow-up in 6 months, 1 year, on at least for 3 years. We exclude reviews, multi-review, editorial or case report without limitation of year of study. The primary outcome was cardiac death to assess safety and TVR to assess the efficacy. Secondary outcome, we find TLR, stent thrombosis, myocardial infection, and all-cause mortality. This is the PRISMA study. In the CLI, we found 186, and then we remove as our criteria inclusion and exclusion. So in the end, we have 11 study. This is the study that we choose in the end, and we make three group. Study will have done follow-up for 6 months, 1 year, and at least for 3 years follow-up. And this is result for cardiac death. We see that in the 6 months, 1 year, or 3 year, there is no significant difference between two-stent strategy and professional strategy in cardiac death. And for the TVR, this is only in 1 year, TVR was significantly lower in two-stent strategy compared to professional stent strategy. And in the 6 months and in 3 year, it's not this significant different. And for target lesion, there is only in 1 year that two strategy is better than professional stent, with the risk ratio is 0.48 and the P is 0.0001. And for the stent thrombosis, it's no significant difference between two-stent strategy or professional strategy. Even the last trial, such as definition or TCTAP cross, it's unable to show that two-stent have a better result in the definite stent thrombosis. In myocardial infarction, there is also no significant difference between two-stent strategy and professional stent strategy in 6 months, 1 year, and 3 years. However, in all-cause mortality, we saw that there is no significant difference. And in composite endpoint, after 1 year, two-stent strategy was the composite endpoint was significantly lower in two-stent strategy compared to professional stent strategy, with p-value in 1 year is 0.0008, with risk ratio is 0.96, and in more than 3 years follow-up, the risk ratio is 0.667, with p-value is 0.004. So this is the resume from the this meta-analysis, that two-stent strategy only reduce have a significant lower in composite endpoint after 1 year, and in another primary endpoint, there is no significant difference. However, the study have several limitations. First, most of the study have a different type and technique of two-stent strategy, and most of them use sirolimus eluting stent, as we know as a first generation of drug eluting stent. And second, there is a similar definition of composite endpoint, but not actually same between among the study. And the most important is the heterogeneity of the complexity of bifurcation lesion. I think the complexity is the most important before we start to assess what strategy would we use in this patient. So the conclusion is no difference in safety and efficacy between one stent and two-stent strategy. However, two-stent strategy significantly reduce the risk of composite endpoint after 1 year. And the take-home message is the assessment of the complexity of coronary bifurcation lesion is very important to determine the strategy which we selected. And in the general, the use of professional strategy is recommended. Thank you.
Thank you very much. So this paper is now open for questions. Any comments?
Yeah, I mean, so when it comes to bifurcation stenting, I think it's a very specific field. And bifurcation stenting depends on a lot of factors here. But before that, the EBC recommends or recommendation is still a single stent technique unless it's absolutely clearly indicated from the onset. But you know, when it comes to bifurcation stenting, most of us, even though we do complex angioplasty, most of us only do about 4 to 6% of dedicated two-stent techniques per year. And that's actually not a lot. So the question is, how can you master all kinds of techniques here? Are you going to be a jack of all trades, or are you just going to master one technique? So the success of bifurcation stenting depends on the center. Is this purely a center that does, a referral center for just bifurcation stents? How good are the support? How good are the doctors doing this bifurcation stenting? So that's why, as you had clearly mentioned just now, the limitation number 3, it is a very heterogeneous group of disease, and it's very specific towards the center, the doctor, the lesion. So I think we can go on and on, but I still think at the end of the day, I still feel that provisional a single stent technique is how we go, in my opinion.
Thank you, sir. I agree with you that bifurcation lesion is a complex lesion. Is the successful is not dependent on only on the stent technique that the operator use, but it's also by lesion, by operator, and by the center. I agree with you. Thank you. Thank you very much.
So as the Dr. Ramesh said, it's very important the experience of the operator for the bifurcation, and I think that the young people should get take a hand on the two-stent strategy, because when you face a bifurcation, and if you don't know the two-stent strategy, the different two-stent strategies, then you go to the provisional, and then you have a problem, and then you have the bad result when you put a second stent not as should be, or to plan the strategy from the beginning. And also the imaging, I think the imaging is very important, or the physiology, FFR or IFR, whatever it is. Thank you very much. Other questions?
Thank you very much, sir.
Thank you very much for your presentation, and I will ask my co-moderator to present the next presenter.
Yes, next presenter is Dr. Wanha from Poland, and his title is Procedural and 1-Year Outcome Following Large Vessel Coronary Artery Perforation Treated by Covered Stent Implantation. Please start.
Chairman, dear colleagues, I would like to present the results of our multi-center crack registry, in which we evaluate the covered stents implantation in the large vessel coronary artery perforation. I don't have any potential conflict of interest regarding to the current study and to the current presentation. The coronary artery perforation is a challenging PCI complication which is associated with significant morbidity and mortality, and the data regarding the clinical outcomes of covered stents used to seal coronary artery perforation in all-comer population are scarce. However, data from other centers show that perforation incidence is the growing problem, probably because of rising number of complex PCI. The aim of the multi-center crack registry was to evaluate the procedural 30 days and 1-year outcomes after coronary artery perforations treated by covered stents implantation. This multi-center all-comer registry included data of consecutive patients with iatrogenic coronary artery perforation treated by covered stent implantation. The study population consists of 119 patients. During PCI, peri-procedural death occurred in 6% of the patients. Emergency cardiac surgery was noted in 10% of the patients, and the successful embolization was achieved in more than 80% of the patients. And in those group of patients, we performed the follow-up of 30 days and 1 year. The primary endpoint was composite adverse of MACE, and the key secondary endpoint was cardiovascular death, myocardial infarction, stent thrombosis, and target lesion revascularization. The patient characteristic shows that the mean age of the patient was 68 years, and 55% were male gender. Most of the patients had PCI because of the acute coronary syndrome, and 38% had PCI because of the chronic coronary syndrome. The angiographic and the procedural data showed that most patients had one vessel disease, and the most treated vessel was LAD. The most prevalent of the perforation was type C, and most common lesion type, according to the ACC and AHA classification was type C. In the current registry, we used 5 types of cover stents, mostly graft master and PK papyrus. Other stents were used less than 5%. The graft master were using 42%, and the PK papyrus was used more because of 46% of the patients. The peri-procedural data showed that the pericardial tamponade was observed in 28% of the patients, cardiogenic shock in 25%, peri-procedural cardiac arrest was observed in 16%, and pericardiocentesis was done in 38% of the patients. The mechanical circulatory support was used in 12% of the patients. Following successful embolization, the cumulative 30 days MACE incidence were observed in 15 patients. Of those, 6 patients had cardiac death, 8 patients had target lesion revascularization, and 6 patients had MI. Furthermore, 4 patients had acute stent thrombosis, and 1 patient had subacute stent thrombosis. However, during 12-month follow-up, the cumulative MACE incidence were observed in 26% of the patients. Of those, 7 patients experienced cardiac death, 13 patients had target lesion revascularization, and 11 patients had MI. 1 patient had late stent thrombosis during 1-year follow-up. Here you see the results of the 1-year Kaplan course of the incidence of the MACE. As you see, most incidents were noted in first 200 days after complicated PCI. The conclusion of the current multi-center observational study showed that the implantation of cover stent is a successful treatment of coronary artery perforation. In our study, we achieved the result of more than 83 successfully treated perforations by cover stent implantation. This real-life registry illustrated the procedural and 1-year outcomes of coronary artery perforation treated by cover stent implantation warrant diligent follow-up of patients as they are increased of the risk of MACE, probably mostly because of the stent thrombosis. And even though stent thrombosis were the further studies and use of intravascular imaging to optimize the cover stent implantation. Thank you.
Okay, thank you very much for your fantastic presentation. That is the nightmare for any one of us. Questions from the audience, panel, and my co-moderator?
Yes, let me ask, do you compare the result, technical result, and result comparing the graft master and the papyrus?
We compared the results of graft master and PK papyrus, and the MACE was the same in PK papyrus and graft master during 1-year follow-up, 12%.
Well, one question that your study is really very interesting, and at the end, your suggestion, as I see that at 1 year you have 26 patients with the perforation and cover stent have 26% of unfavorable outcome. Your suggestion to put as a regularly control angiography at probably 3 months, because I saw that the most events are in the beginning, in the first several months. So to put a follow-up, angiographically follow-up at the 3 months, is it advisable?
Of course, I recommend to perform the follow-up angiography in first 200 days, and probably with intravascular imaging, because most of those stents could be undeployment, and it could be a reason of stent thrombosis, which is observed in the follow-up.
One another question. In my practice, I don't have many perforations, fortunately, thanks to God. But when I have a perforation and when I put a cover stent off-label, I put over the cover stent a drug-eluting stent, just to reduce the risk of the thrombosis and also of the restenosis. What do you think about this off-label technique?
All right. What do you think about the drug-eluting balloons compared to drug-eluting stents?
Well, practically, I think the drug will be a little bit difficult to penetrate inside of the, I don't know whether it can penetrate inside of the stent. I mean, the drug Eluting balloon is for the tissue, not for the stent. But anyway, thank you very much, Dr. Vanha from Poland for your presentation. And I give the word to my co-moderator to present the next presenter.
Okay, next presenter is Dr. Uma from Birmingham. And the title is Incidence, Registers, and Management of Coronary Artery Perforation in the Contemporary 10-year dataset. Please start.
My name's Hamza. I'm one of the fourth-year medical students at the University of Birmingham. And today I'm going to be presenting my research on coronary artery perforation. So I'd like to express that there were no conflicts of interests involved in this study. So a bit of background about coronary artery perforation. So what do we already know? We know that it's an iatrogenic and rare complication of PCI with a reported incidence of roughly 0.43%. And it's typically graded according to the Ellis criteria, where type 3 is the most life-threatening, as it can lead to pericardial tamponade and death as a result. And we know that there are different management options available for interventional cardiologists, such as covered stents, coronary coils, balloon tamponade, and even cabbage. And we know that a variety of factors increase the risk of CAP or are predictive of CAP. So in our study, we didn't use the normal Ellis criteria, we used a modified version. And this differentiates CAP into 5 types rather than 3. And you can see here down at the bottom that there are 2 additional types. So type 4 is defined as accumulation of blood into another anatomical cavity. And type 5 is synonymous with a distal perforation. So this is the classification that we used. So the factors that are predicted of CAP, we can, broadly speaking, we can categorize them into 3 different types. So they're patient factors, they are angiographic factors, and they are operator factors that are all possibly predictive or contribute to the increased incidence of CAP. So the patient factors include female, age, and comorbidities. And the operator factors include intravascular ultrasound, rote ablation, and the angiographic factors include all of this, including chronic total occlusions. So the aims and objectives of our study, we saw that there was a growing incidence of coronary artery perforation over a 10-year period, and we want to understand why that was the case. So are the aforementioned factors similar or different in our database? So in order to determine this, we carried out a retrospective cohort study to identify changing predictors in CAP. So the methods. So we had the total PCI database and we extracted all the CAP cases. And then what we did was interesting. We categorized the different CAPs according to the time period it took place in. So the CAP cohort was split into 2, cohort A and cohort B, and each was representative of a different 5-year period within the decade. And we also included the PCI database, which behaved as the control group. And we collected the data on the baseline and angiographic characteristics, management options, and outcomes. And all the angiograms, they were screened to all the identified CAP cases, the angiograms were screened. And then that allowed us to grade the perforation according to the modified Ellis criteria and to comment on the vessel anatomy too. So what we saw overall within the CAP database, there were 66 cases. The overall incidence was 0.69%. But when we split it according to the 5-year periods, we found that in cohort B, there was a growing incidence, which was 0.81%. So we want to know why this was the case. Why was this so high compared to cohort A? So I'd like to highlight some of the baseline characteristics that we observed. So if you look at cohort B in comparison to cohort A, we saw a greater number of diabetics, patients with stable angina, chronic kidney disease, MI, and peripheral vascular disease. And I'd also like to comment on the demographics overall within both cohorts. Interestingly, there were less females population within cohort B compared to cohort A, and that's something I would like to discuss later on. So going on to the angiographic and procedural characteristics. In cohort B, there was a greater number of chronic total occlusions attempted. there was a greater number of C-type lesions, there's a greater number of intravascular ultrasound use and rotablation. And these are all surrogates for complex PCI and could be a reason why we saw the growing incidence. And going on to the management. So in cohort B, straight away you can see that there was a greater variety of treatment modalities used to treat CAP compared to cohort A. And we also saw a greater number of type 3 perforations compared to cohort A. And as a consequence, the outcomes were a lot worse. So we observed more death, more tamponade, and the need for emergency CABG surgery. And that moves me on to my discussion points. So interestingly, a lot of the literature, it has pointed towards the fact that female gender is predictive of CAP. But what we observed in cohort A, so if I go back to this, we saw that the population was lower. So is it truly one of the incidence predictors of CAP? So that's something that I would like to investigate further. And we know that PCI complexity correlates with the increased incidence of CAP. And what we saw in cohort A, we saw an increase in rotablation, increase in IVUS, and an increase in CTOs attempted. And that could be a reason why we saw an increase in incidence. And something else that I would like to investigate, what are the true predictors of CAP? And that moves me on to my conclusion. So our demographic represents an aging population with a greater number of comorbidities. And cohort B is reflective of the future demographic or patient type that we will be observing at our center. Surrogates for complex PCI correlate with an increased incidence of CAP, and pericardial tamponade was found to be a poor prognostic factor. And as a consequence of all of this, CAPs are likely to persist in future. Thank you very much for your time.
Dr. Umar, thank you very much for your presentation, and really young guy with such interesting, scientifically oriented investigation about the perforation that probably I hope and I wish that doesn't happen to you. Questions from the audience? Well, I have one question. It's really difficult to understand why you face the perforation. It's really difficult. Probably there are many reasons, but we try to forget them. But in your analysis, I saw that the kidney disease was one of the important predictors of probably a probable perforation. How you explain that kidney disease, and which grade of kidney disease?
From my limited knowledge as a medical student, this is completely probably a guess, but there might be an increase in calcification to the vessels as a consequence of kidney disease.
Absolutely right.
And that could lead to increased rate in perforation.
Dr. Umar, you're promoted. We wish you
I'm still in medical,
a
so I don't have
fantastic career in your life and in your professional work. So we can continue with the next presentation, Dr. Takagi.
Yes, the final presenter is Dr. Chen from Fouladvand Hospital, China, and the long-term outcomes of the Percutaneous coronary intervention versus coronary artery bypass surgery in elderly patients with multi-vessel and or left main coronary artery disease and diabetes mellitus. Please start your presentation.
My name is Zhen Jianfeng. I came from the Fouladvand Hospital, Beijing. It's my honor to introduce our research, the long-term outcome of percutaneous coronary intervention versus coronary arterial bypass surgery in elder patients with multi-vessel and or left main coronary arterial disease and diabetes mellitus. Assistant review and meta-analysis. The authors have no financial conflicts of interest to disclose concerning the presentation. As we know, the diabetes mellitus as a global burden has brought a big threat to international public health, and the patient with diabetes has a two-word story for the increase in the incidence of coronary heart disease. So the risk of developing coronary vascular complication among patients with diabetes is further compared by age. And there is still some considerable debates about the comparative benefits and the risk of coronary arterial bypass grafting and PCI in elder patients. So our meta-analysis was performed to compare these 2 months of the superior revascular strategies among PCI and cabbage. And there is our MENSO, an electric search of the recent study from 2009 to 2019 was carried out using the diabetic mellitus coronary artery bypass graft and the percutaneous coronary intervention as the main searching stern. Here is the and the data software was used. The selected criteria was the clinical traits that include patient with multiracial or left main coronary arterial disease and diabetes. And the third is the comparison of the PCI versus cabbage. And the the next is the RCT observer study and a saved article with pre-establishing subgroup analysis. And the final, the clinical follow-up time equal to greater than 1 year was included in our studies. This chart flow was our shows our benzos research in the PubMed, InBase, Coherent, and other database. And finally, we get 14 studies in our quantitative analysis studies and analysis. Here is our results. Among these observed studies, PCI and cabbage patients didn't differ significantly in the rates of the stroke, cerebral vascular events, cerebral vascular accidents, and the cardiovascular deaths. However, the rates of the major adverse of the cardiac cerebral events, all-cause deaths, myocardial infarction, and any repeat revasculars were significantly higher in the PCI group. Although there was no significant difference of the MI and the stroke and cerebral vasculation among these RCT studies, the cabbage significant had no low-cause deaths, cardiac deaths, and any repeat revasculations. This table 1 shows that the general characters of the included the 14 studies, and there are about 3 RCTs and 11 observer studies. And these are the dates we extracted from the studies. Here is the forest plot of the randomized culture RCT studies. As we can see, the all-cause days and the any repeat revasculation and the cardiovascular deaths and the masses had a significant difference between the PCI and the cabbage, which favor the cabbage. However, it's interesting found that in this observer studies, we can see that the masses and the all-cause deaths and the myocardial infarction, any repeated revascular is the same as the RCT, shows that the cabbage has the favor compared to the PCI. And the publication basis and the sensitives also show that there was no differences. So there are some discussing points we take. First is the different outcome between the PCI and cabbage and the RCT and the observer studies. Second is the optimal therapy strategies among this older patient with multiracial and the left main coronary artery disease. In our study, we conclude that in a short-term follow-up for artery perforation, it might be a reduction in the rate of the stroke, cerebral vascular events of PCI compared with cabbage. And the choice of the technique for elder patient may be made considering autonomous clinical complications of careful angle and our operator experience. Despite the high point risk of a stroke, cerebral vascular events and cerebral vascular accidents, cabbage was better than PCI for diabetic elder patient with multiracial and left main coronary artery disease. Here are some limitations also in our studies, like the dates on the pre-operative medicine therapy, and the degree of coronary artery stenosis, glycemic culture level, and so on were scary to analyze. And it's also difficult to ascertain the complexity of the underlying coronary arteries in these studies. And the primary endpoints might be different in these studies. Finally, the follow-up period varied among the study, and this may also contribute to the heterogeneity. So that's all. Thank you. Thank you for your attention.
Thank you very much, Dr. Zhang, for your interesting presentation. It's a question which is always to treat or not to treat with angioplasty this type of patients. Questions from the audience or from the panel? Well, we are without words in front of your presentation. Well, I think that I'm a practical interventional cardiologist for 30 years, and I really believe in the randomized studies. In such a type of putting together all things, patients with the diabetes, patients with the left main, angle of the left main, multivessel disease, type of the stents, type of the techniques, experience of the operator, techniques used like imaging or not, everything becomes very difficult to take some decision, really. But I agree with you that at the end, diabetic patients with multivessel disease is better to be treated by bypass, except if there are some limitations or contraindications to perform that. Questions? Dr. Takagi, as I see from the pictures, you are almost like me at the age and the experience. What do you think about that?
Well, I agree with you, but patient included in the randomized study, the complexity of the region or the complexity of the patient is a little different from the real world, maybe. So,
I agree with you.
So let me say, so if the patient is 90 years old diabetic with CKD, do we have to send him to the cardiac surgery? So we have to see the result. Yeah.
Thank you.
Dr. Ramesh, you?
So I echo your words. I mean, diabetes is a unique disorder, and especially if your ejection fraction is on the lower side, multivessel disease, it is always bypass surgery for me. However, I just like to point out, if you look at the ischemia CKD arm, if the patient has diabetes and even if it's stable coronary artery disease, I think sometimes with these patients, you can actually manage them medically. I agree with the ischemia CKD arm. I don't necessarily agree with the ischemia non-CKD arm, but the CKD arm, I think I will treat them conservatively, especially in the elderly.
Thank you, Farhat.
To all the participants, what about when you have a patient with a multivessel disease, to use a physiology to downgrade the patient, the multivessel disease, to become a less multivessel? I think it's really very important, but we are using 5% of our cases, the physiology to evaluate the real impact of the ischemia or whether there is ischemia or not. Anyway, thank you very much to all presenters, especially to all presenters. Thank you very much to the panel, to my co-moderator, Dr. Takagi. If there are not any other questions, I wish to all of you a really very good career in your life. And thank you very much for your participation. Dr. Takagi?
Thank you very much. So we're closing this session. Thank you for your cooperation.
Thank you. Thank you to all of you. Thank you.
Thank you for you.
Thank you very much.
Thank you.
I'm sad really that you cannot see Seoul, because Seoul is really a very good place to see it during the live Congress. But anyway, maybe next year. Okay. Keep safe. Bye. Bye to everybody.
See ya.